Delighted to welcome you to our annual lecture for this year. Before I introduce our guest speaker, I'd like to acknowledge the traditional owners of the various lands on which we meet throughout Australia today, and to also welcome any Aboriginal and Torres Strait Islander people who might be joining us. I'd especially like to pay my respects to the Aboriginal elders past and present. They hold the memories and traditions, culture and hopes of Aboriginal Australia. Our guest speaker today is Associate Professor Chris Schilling. Chris is a health economist at the University of Melbourne, and he's worked in senior positions across academia, government and consultancy. At the University of Melbourne, Chris is the lead health economist on several projects, and his research priorities include developing models to evaluate interventions, advancing the evidence base around the economics of palliative care, and reducing low-value care across the Australian healthcare system. Chris was also the lead author on the 2020 Investing to Save the Economics of Palliative Care report, which was commissioned by Palliative Care Australia. He's a strong advocate of palliative care, and I think his presentation is particularly pertinent today, as I think we're all aware of some of the significant healthcare costs and resource implications for palliative care across our nation at present. With regard to the proceedings today, I would like you to use the opportunity of raising questions, which we will allow some time for at the end of Chris's presentation. There's a Q&A function you can use, and I would encourage you strongly to log your questions as we go along, rather than waiting till the very end. So we'd really greatly appreciate if you could do that. I'll now hand over to Chris, and welcome Chris, and thank you again on behalf of all of us. Look forward to your presentation. Thank you very much.
Thanks, Peter, and thanks all for joining. Apologies, I seem to be having some camera issues at the moment, but I can share my slides and continue that notwithstanding. In our practice runs, the camera does seem to come and go a little bit, so hopefully it's improved across the presentation. The presentation I'm sharing today, and I'll just pull it up, really stems from the work that we did initially back in 2020 with Palliative Care Australia, where we researched the economics of palliative care and tried to make the case for investing further funding into palliative care resources. I mean, I can remember at the time thinking that really how naive I was around, firstly, around palliative care in general, and secondly, around the economics of palliative care. So I'm super excited to kind of reflect on that report 3 years ago, because it's actually been really seminal to my professional career, and it's led me to really to change my focus. So I have returned to academia 3 years on, and I'm now leading a small but growing team of health economists with a focus on really expanding the research around the economics of palliative care. And so as part of that, one of the first steps was to do a review of the current evidence base, and that's what I'll be really summarising today when I walk through the slides with you. So really the aims of today, the primary aims are to make sure that you walk away with an overview of the latest evidence around the impact of palliative care on health service use and costs, and evidence of cost effectiveness of palliative care. I want to take the time to also highlight areas where there are still gaps, and you'll see that I use the analogy of a patchwork quilt through the presentation. So we see areas where we've got good evidence, but areas where there are still gaps as well. And along the presentation, I also want to take the opportunity just to introduce you into the language and intuition of of economics and economic evaluation. I know that it can be confusing. We do have a jargon and a lexicon that we tend to use, and so I want to take the opportunity to try and simplify a little bit of that while we're going through the evidence base as well, so that you do walk away with a better understanding more broadly of the economics and the economics of palliative care. And so if I start firstly just with a couple of slides around the economic context, and particularly about what economics is and what it isn't. I mean, one of the things that's often confused around economics is that it's all just about the dollars and cents. When actually that's not exactly right. So what economics is really concerned with is the allocation of scarce resources. So what do we mean by resources? Well, we think of things like labour and capital in the typical sense, but we also think about things like the environment. That's certainly a scarce resource. We think about things like budgets, government funding. That's also certainly scarce. And if you're a clinician seeing patients, then your time is also particularly scarce. And so what economics tries to do is really just provide tools, techniques, methods for understanding how we make best use of the resources that we've got at hand to really maximise the outcomes from those resources. And so you've probably heard at some point around the idea of opportunity costs. That's the idea that because resources are scarce, we could be using them in other ways. And so economics is always thinking about, well, how are we adding value by using resources in a certain way? And it's that incremental approach, that incremental effectiveness and that incremental cost effectiveness that economics is really interested in. And in terms of health economics, we take those methods and those approaches and we apply it to how we make decisions around what we should fund, for example. And so we use economics to try and inform and influence the choices and decisions that we make around our healthcare system. And in terms of the specific methods that health economics provides, one of the key ones is what's known as economic evaluation. And that absolutely starts with that premise that I've highlighted around resources being scarce. And really the aim there is to maximise the health gain that we're able to get from a given budget. And so what we do and what economic evaluation does is just try and compare those costs and outcomes. So there is a lot of language and a lot of jargon around it, but at its essence, it's really a simple comparison where we're looking at how an intervention improves outcomes versus the cost, the additional cost that it takes to do that. And what we see is that by using these really clear and explicit methods, we're actually able to really help decision making. And so economic evaluation is widely used by government. In fact, this morning I was on a call with the PBAC and going through the rounds that they go through, and they look at the economic evaluation of different drugs and different devices to decide which ones will be funded and which ones won't be. And so it is critical that we do take that lens and we do investigate not just improvements in outcomes, but we look at costs and the economics as well. And it's critical because because costs are rising and budgets are finite. We simply as a country don't have and as a government we don't have the budgets to spend on all the things that we potentially like to spend on. And the graphs on this slide are from the intergenerational report that was released earlier this year, and it projects out for the next 20 and 30 and 40 years what we'll be spending government funding on. And as you can see, as a share of both GDP and as just a dollar value per person, that we expect to be spending more and more and more on healthcare. And so that puts pressure on making sure that we're getting good bang for our buck from that spending. And I know here in Victoria, there's already been examples where as we've needed to cut back budgets, as the state government's needed to restrict its outlays, that's then cascaded down to cuts at the Department of Health and cuts to funding of palliative care. And so as a sector, we've got to be really clear that we're able to highlight that palliative care is a cost-effective intervention and one that makes sense, not just ethically and not just from a patient perspective, but also from an economic one. I'll just take a few moments now just to walk through one of the standard diagrams that we use to evaluate cost effectiveness. It's called a cost effectiveness plane. And there are a few different elements to a cost effectiveness plane. On the x-axis, we've got outcomes. On the y-axis, we've got costs. And at the origin, at the 0 point, we've got essentially C standing for our comparator, where we are with our current status quo treatments. And so what we do in economic evaluation is we compare potential new interventions and new treatments with where we are today. And so, for example, a new intervention may deliver better outcomes at a lower cost. And if it's able to do that, then it's a bit of a no-brainer for us. It's what we call a dominant intervention. And we say, yep, that makes a whole lot of sense for us to fund, because not only is it delivering better outcomes than the current treatment that we use today, it's actually delivering cost savings as well. So it's a win on both dimensions. So it's a bit of a no-brainer. Similarly, there's the opposite. Where a new intervention actually might be both less effective as well as more costly. And that similarly is an easy decision for funders. When they see this, there'd need to be a whole lot of other reasons for them to fund it, because in general, this isn't something that's delivering anything better or any more optimal than what we've already got in terms of our status quo treatment. But they're kind of the easy two parts of the plane. When we move over to the top right-hand corner, things get a little bit trickier, because in these situations, and they're very common, in actual fact, the most common situations, we see that a new intervention might be more effective, so it's improving outcomes relative to where we are today, but it's costing more. And so in these situations, it's not clear cut whether or not we should fund this new intervention. It's not clear cut whether this new intervention is cost effective or not. And so in these instances, what we use is a threshold to say, well, is that improvement in outcomes enough to justify that extra cost? And that's typically considered through what we call an incremental cost effectiveness threshold. And you might have heard of the kind of the rule of thumb that's often used around that, which is that threshold of $50,000 per QALY. Now, the PBAC and MSAC, so the government bodies that are designed to decide on what to fund, don't use exactly that threshold. They might move it up and down a little bit depending on certain features of the interventions, but as a rule of thumb, it's a pretty good one. And so when an intervention comes in below that threshold, it's typically deemed cost effective. When it comes in above that threshold, it's typically deemed not cost effective. And so really then the interesting thing starts, or the interesting question starts to be, well, where does palliative care sit on such a plane? Is it over here in the red part of the diagram? Where it's really not cost effective, or is it down here in the green where it clearly is? And I think what we'll try and do today is just provide the evidence base to give you an understanding as to, well, what does the evidence say about where palliative care kind of sits on this diagram? Because I think the misconceptions around palliative care are that it's only provided really to those who are literally dying in the next hours, and so doesn't add a lot of value. And so on a graph like this, it might suggest that you are in the red part of that graph. But what I'll be able to walk through is that, as I'm sure all of you in the audience know, that that's really not the case, and that is really a misconception around palliative care. So now we'll move on to going through that evidence base. And I want to take the time to walk through how we've gone about establishing the evidence. And we've really started with looking at the best quality of evidence that we can get our hands on. And that's typically systematic reviews and meta-analyses. These studies collate all of the information and all of the findings from studies that have been done, and they try and combine them in a way that then says, well, overall, do we see a really strong signal out of the research that's been done to date? And so you'll see in the hierarchy of evidence, systematic reviews and meta-analyses are at the top, because they are providing that highest quality of evidence. And so in terms of what we've done to review the evidence, our first stop has been to look at systematic reviews and meta-analyses. One of the interesting things, though, with that approach is that systematic reviews and meta-analyses tend to focus on studies that have been randomised control trials. And while randomised control trials are also a very high level of quality in terms of that hierarchy of evidence, they tend to be powered for outcomes and not necessarily powered for costs and economic impacts. And so what we often find is that an RCT might be able to show a difference in terms of a clinical outcome, but because of the way that costs are so varied and typically the distribution of costs are so skewed, that it might not be able to show a statistical significance in terms of cost differences. In that situation, and then because of that, what we've also included in this review is studies that aren't necessarily RCTs. So we've looked at cohort studies that have been able to use really large administrative data sets and really improve the power of what they're looking at, because they're looking at literally tens of thousands of patients over time. And so we've included those to kind of add further information on top of what we see in the systematic reviews and meta-analyses. And the other dimension that we've also strongly considered is the fact that a lot of the systematic reviews and meta-analyses will be looking at international evidence, and we wanted to make sure that we're also considering the generalisability of that to Australia. And so we do also, and you'll see through the presentation, pick out 2 or 3 or 4 of the really important Australian studies that are clearly generalisable to Australia and have clear implications for the sector. So before I get into the key results, which I'm sure you're all actually the most keen to see, I did want to just highlight some caveats around the work. And I mentioned earlier this idea of a patchwork quilt of evidence, because as you'll see when we piece it together, that it's not a full complete shade of black or white. It's shades of greys and certain components and certain settings and certain particular types of palliative care might be covered, but others might not be. And so essentially what we're trying to do is just cover as much as we can, but do so in a rigorous and robust way. My research assistant Florencia and I have uncovered over 20 systematic reviews over the last couple of months that we've been working our way through. We've noticed that in some of those that they're overlapped, and so they're calling on the same study to inform their findings. So we've had to kind of work our way through that. Because we are doing this summary of evidence, we are pulling different studies from different parts of the world. And what that typically means is that there can be inconsistent definitions. There can be inconsistent definitions about exactly what we're talking about with palliative care. Typically that the focus has been specialist palliative care. And by that, typically, the literature is referring to at least one clinician with specialty palliative care training, but it's not uniquely defined. And so I do ask you to bear with us when we go through and we kind of use a pretty broad definition. It's just so that we can combine the different parts of the evidence. And you'll see that there's also inconsistent definitions even in terms of the settings and how they're kind of described. But overall, as I say, we are kind of, and what we have attempted to do is really to piece this patchwork quilt together. Finally, the last limitation I do want to just be really upfront about to note is that we have tried our best to make sure we haven't overlooked any studies, but there may absolutely be the case where your seminal paper hasn't been included. And if so, I apologise up front. This is work in progress, so please do reach out to me if we have missed any key research. We'd like nothing more than to hear about any great pieces of evidence that you're working on. So without any further ado, I'll jump straight into it. And we started off firstly with a Cochrane review, Bajwar et al. In 2020. And they did a review on the effectiveness and cost effectiveness of palliative care. They included 42 randomised control trials, of which 3 were Australian, out to a published date of August 2019. The patient cohort considered all adults, so both cancer and non-cancer illnesses. And the interventions and settings were really hospital-based specialist palliative care, but provided in kind of different ways. So whether that be inpatient in the hospital, in the ward, or inpatient consults, outpatient, or hospital in the home or outreach. And while the majority of the results that I'm going to highlight today are all focused on health service use and cost effectiveness, I did just want to highlight one on outcomes, because I think, as I mentioned at the start in the intro, that there is this misconception that while palliative care doesn't cause poor outcomes, it perhaps doesn't improve outcomes. And what I can tell you is from this systematic review that actually there is really strong evidence that palliative care makes a small but significant effect on health-related quality of life, i.e. it does improve outcomes. This is a table and a figure from that systematic review, and it's got a forest plot here, and what we're showing here is essentially the summary of all the studies that have highlighted a health-related quality of life outcome. And the overall result has been that there's been as I say, a small but significant effect that palliative care has indeed resulted in better outcomes. And so when we think back to that chart that I was showing initially, then straight away we're actually able to show that palliative care is kind of moving over here on the right side in terms of incremental outcomes. That's really important because, as I say, too often I think that there's this misconception that palliative care really doesn't make any impact on outcomes, and that's not the case. So from here, I'll move back to where the focus will be from here on in, and that's on health service utilisation. And really interestingly, the Bajwar et al. Cochrane review paper doesn't find any consistent results around health service utilisation. So it quotes a very low quality of evidence around the effect of specialist palliative care compared to usual care on resource utilisation, cost and cost effectiveness. And really, when you work through that paper, it's that the results are inconsistent. It's not saying that palliative care necessarily increases health service utilisation. It's just saying that there wasn't a clear result. But as I mentioned in the discussion of methods, that's not necessarily surprising because this study focused on randomised control trials, and randomised control trials aren't typically powered to identify differences in costs. And so when we look at our first start of our patchwork quilt, we do see essentially yellow inconsistent evidence around the impact of palliative care on an adult cohort in terms of its impact on ED visits or hospitalisations. But when we look across to the quality, we see that, yes, it was a high quality systematic review, but really it wasn't powered to generate the results around health service utilisation. And typically the generalisability is low because the vast majority of studies are international and not Australian or focused on our healthcare system. And so from here we moved onto another systematic review. This was a JAMA systematic review done by Quinn et al., 28 RCTs to April 2020. There was an overlap with the previous study, but not a complete overlap. The interventions were broader interventions than the hospital-based palliative care interventions that the Bargewar et al. Paper focused on. And the cohort was different in that it focused specifically on non-cancer diseases, non-cancer chronic life-limiting diseases, rather than cancer and non-cancer diseases. And what this study found in terms of the impact of palliative care on ED attendances, and again looking at this this forest plot, is that across all of the studies that reported results around impact of palliative care on ED attendances, the overall result was a significant one, suggesting that palliative care was associated with 12% less ED attendances than standard care. So a positive result there for palliative care, and similarly for hospitalisations, the same result was found, or a similar result, actually a slightly bigger one, in suggesting that 20% less hospitalisations were experienced for those who had access to palliative care in different forms. And so we start to build the evidence base further, and we start to add some greens here to our results around ED visits and hospitalisations. And we note that the evidence, again, was high. It was a systematic review, but that the power issues and the generalisability issues were potentially still limiting what we can say. And so from here, we moved on to a meta-analysis that Peter May, one of, if not the best palliative care health economists in the world, at least up there as one of them, conducted in 2018. And really the key thing here that May et al. Did was that they expanded their search from just randomised control trials to also include cohort studies. And so they did a meta-analysis because they were able to actually combine the data in that in a consistent way. And they looked at, as I say, 6 big cohort studies from April 2013 to April 2017. The intervention was a little bit narrower than what Quinn et al. Was looking at. It was specifically palliative care consultations in hospital settings, but the cohort was, again, all adults and all diseases. And what May et al. Found when they looked at the specifics of the economics of palliative care for hospitalised adults, they found a significant reduction of over $3,000 US. So when you look at this overall pooled result of the 6 overall studies, the hospital costs were over $3,000 US lower for the palliative care group. And so we add that to our patchwork quilt. We see that hospitalisations and costs are again highlighting significant reductions from palliative care. That it was a high-quality meta-analysis, but it also included cohort studies. It was based on cohort studies, so it did have that power to identify significant differences in costs and resource use. But the one thing in terms of its generalisability was that it considered only US studies, and it didn't consider any Australian studies, or there weren't any to consider. And so what's great now to relay to the audience is that there has been a really impressive Australian study that's just been published by a great team up in New South Wales. And this was just published in Pharmacoeconomics. And what this study did was make use of a big linked data set, the 45 and up data set, and was able to look at over 10,000 people with cancer and 11,000 people with other life-limiting illnesses, and essentially compare those who accessed palliative care to those who didn't, and look at end-of-life costs in that last 12 months of life. And so great thing here is we're able to add an Australian-specific large cohort study to this evidence base. And so here the findings from Kenny et al. And are a little bit hard to decipher from the graph, but I'll try and help you out here. These graphs, it's the easiest one to look at is the non-cancer one, and this graph is comparing the impact on hospitalisation costs for those who had palliative care to those who didn't. And the different lines are the timing of palliative care. And so the optimal timing of palliative care is this kind of more red line, which said that if specialist palliative care was provided at least 180 days before death, then when you get to within 6 months of death, you see that that overall hospital costs were significantly lower than those who hadn't accessed palliative care. The interesting thing here is so firstly, it's a really positive result again using a fantastic administrative data set, and the study and the team did adjust for selection bias on things that they did observe in the data set. So they did try and make sure that the groups between those who got palliative care and those who didn't were adjusted for in terms of any underlying differences. But they could only do that with with the information that they observed in those data sets. And so they themselves note that there is some untangling or some disentangling still to do around the causality of these results. And particularly highlight that earlier on, so that the kind of the full year costs are actually higher for those who had accessed palliative care. So adding that to the patchwork quilt, and again, fantastic new evidence, lower 30-day and low 6-month costs, but higher 1-year costs. The evidence is a lower quality of evidence because it's a cohort study and not a randomized controlled trial or systematic review or meta-analysis, but it does have that power to identify differences because of its size, and it does have that high relevance because it's based here in Australia and using New South Wales administrative data set. So an impressive piece of evidence and another piece to add to the mix. But one of the issues was really just about the selection, because it's really focused on associations and really uncovering whether or not there were differences between the two groups between the groups who received palliative care and who didn't can be still challenging. And so what we draw your attention to now is a further systematic review that was done by Jiang et al. Just this year, or published just this year. And what it did was collate all the studies that had done a similar study to what we'd just seen, but had added in quasi-experimental methods to try and help paint that picture of black and white in terms of that causality a little bit clearer. Quasi-experimental methods are methods that try to make use of natural variation. So we might see that one hospital, for example, introduced a certain palliative care service where another didn't. And so we're able to use that variation then to paint a clearer picture as to the impact of palliative care. And so there are these quasi-experimental methods, difference in difference methods, or regression discontinuity methods, or instrumental variable approaches that essentially use a novel feature to try and tease out the causality a little bit further than what a cohort study can. And so what the findings from this systematic review were still really strongly positive for palliative care interventions in general. So found that they reduced healthcare costs, lowered healthcare utilisation. So exactly what we're seeing. So really positive that even after including a more robust study design, that they still found this. But what they did note that the magnitude of the estimated cost savings reduced. It was a bit lower when we used this more rigorous research design. So that's a really good learning for us. It means that when we do cohort studies, that we can still interpret those results, but we do have an evidence to suggest that perhaps we should just temper some of that. It doesn't mean that at all that palliative care is not is not showing as being really positive. It is, but it's just tempering the results slightly. And so we add that to the mix again, and we see that that's really high quality evidence with really large samples that really add to this patchwork quilt of evidence. I want to move now quickly to specialist community and home-based palliative care, because there's been a couple of recent systematic reviews that have really focused on these settings and palliative and the impact of palliative care in home and community-based settings. McCarroll et al. Had 8 RCTs, 2 Australian from 2001 to 2021, and Gonzalez Jamilo had 21 studies from 19 unique RCTs, but no Australian ones from 2013 to 2019. And again, the cohorts were all adults, and the focus is on community and home-based palliative care here. Clear results and really positive results from these systematic reviews. So the palliative care teams in this population had positive impact on the reduction of hospital admission rates. Same positive impact was reported for emergency department usage rates. And similarly, the second paper found very similar results as well. So reduced the number of hospital visits and their length, as well as hospitalisation costs and overall healthcare costs. So adding that to the mix, we can start to expand from kind of hospital-based palliative care to community and home-based palliative care, and see that the evidence base and that patchwork quilt strongly provides good evidence. The level is high at the systematic reviews, but interestingly, again, some of the issues are around the generalisability to Australia. And on that front, we're able to positively report that actually the McCarroll et al. Study cites 2 fantastic Australian studies, and I'll just quickly walk through both of those now. Those are the Spilsbury et al. 2017 paper and the Ewens and Moran 2017 papers, and they're relatively similar in that they look at the impact of community and home-based palliative care on hospital use and hospital costs in the last year of life. And they use big WA, Western Australian data sets to investigate that. And so the first study had over 12,000, close to 13,000 decedents who died between 2009 and the end of 2010. And the second paper had over 28,000, a sample size of only over 28,000, and so really large cohort studies, clearly relevant to the Australian settings. And in terms of results, again, really strong results in terms of the impact of palliative care on reducing hospitalisations. This graph here is showing on the y-axis a hazard ratio, and then on the x-axis is showing the days before death. And these types of graphs are only possible with such large data sets. But what it really shows clearly is that as patients move closer to death, that the impact of palliative care was to reduce the amount of hospitalisations for the group that received community-based palliative care. So really strong findings there, and the second paper also found very similar results. So we add that again to our patchwork quilt, and we see that in the home and community settings, the first systematic reviews found consistent reductions. And then when we went to the Australian cohort studies, we also found consistent health utilisations or reductions in health service utilisation. So positive kind of evidence building there. Moving on to studies that have looked at nursing homes. There was a recent systematic review of nursing home palliative care by Carpenter et al. In 2020, and it cited 13 RCTs to January 2019 and really looked at a range of various interventions in nursing homes. And what it found was essentially similar to what our first RCT found, was that there were some inconsistencies in terms of the results. 5 out of 9 studies showed reductions in terms of rehospitalizations and acute care admissions, but 4 showed no significant effect. So a little bit of an inconsistent effect. They cited one of Mira Agar's papers, so a specific paper that had been done to look at family case conferencing for dementia sufferers. So a very specific cohort here, and that paper had noted actually that there wasn't an effect that was found in this instance, this very specific instance. The paper also noted, however, though, that the end trial ended up being slightly underpowered, and when they'd looked at the per protocol analysis, that it had indicated reduced health resource use. So a slightly more nuanced result there. And when we add that to the evidence base and really look at what happens in aged care facilities and nursing homes, we see that the systematic review was kind of mixed and inconsistent. And the Agar paper was a very specific paper, and it didn't find an observed effect. So it was the first real red paper there. In terms of a further randomised control study that was done, a really interesting one that was done here in Australia through the ACT in New South Wales, was one by Forbay et al. In 2020. This is one we just started getting the initial results on when we were writing the Investing to Save report. But this was a step wedge randomised control trial. It was essentially looking at specialist palliative care needs rounds in aged care homes, and it found fantastic results in terms of the improvements or the reductions in hospital bed days and hospital admissions for those facilities that had had those needs rounds versus those who hadn't. So adding that to the mix and the effectiveness of palliative care in aged care starts to become more positive, and particularly noting that this was a really highly powered study, and it is a clearly highly generalizable as well, because it crossed a number of facilities. So bear with me, we're getting there. But the last thing when we kind of look at this is that we see there hasn't been a lot of studies that have even attempted to look at cost effectiveness in its totality. Most studies have just been looking at resource use and costs. And so we did also want to highlight to the audience that there was a 2020 systematic review that just focused on economic evaluations of palliative care models. Only 5 studies were found, and only 1 Australian. Positively, the systematic review did conclude that the palliative care was cost effective compared to usual care, and that the quality of the evidence was good overall. But 3 of those 5 studies were based on small sample sizes. Indeed, the Australian study was a pilot at that point. But the beginnings of an evidence base, as I highlight there. Following that study, there was a further Australian modelling exercise that was done by Chow et al. In 2022. and it leveraged that initial pilot by McCaffrey et al. In 2013, and it built a health economic evaluation and decision analytic model on top of it to understand whether palliative care extended packages at home plus usual care was cost effective versus usual care. And it found that in fact, yes, it was that both outcomes improved and costs reduced. So it found that palliative care in this instance was a dominant intervention. And so that comes to the end of our patchwork quilt. And really what I'd just like to do with the last couple of minutes is just to kind of take a deep breath. I know we've gone through a whole lot here, a whole range of studies across a whole range of settings and a whole range of methods. And so if we kind of walk through what has this told us? What is this chart here? What does this figure really kind of tell us around the impact of palliative care? Well, I think firstly, the key point that we take away is that there is high quality evidence that specialist palliative care reduces end of life, hospitalizations, ED visits and costs. I think that's a really clear broad finding. But there are some caveats and there are some patchwork quilt essentially to those findings. And there's some mixed results and some inconsistent results with RCTs because they're typically not powered to be able to really identify clearly significant differences in costs. When there was that meta-analysis by Peter May that was done that looked at specific cohort studies for palliative care, the results were really strong and showed significant reductions in hospitalizations and costs when they used cohort studies with bigger sample sizes. There has been some excellent Australian cohort studies, and they have all showed similar results in terms of reductions in hospitalizations. But one of the next steps was really around, well, can we include more quasi-experimental analyses just to add a little bit more robustness to those studies? And when that had been done in the latest 2023 systematic review with US studies, the findings from that was that palliative care was still strongly cost effective and effective at reducing end of life acute care costs, but just at a lower magnitude. So overall, really positive findings, but clearly the specifics vary by palliative care intervention, by patient cohort and setting. And so if you're making specific cases, please do try and focus on the most relevant piece of evidence for you. But if you're talking more broadly, I think the evidence base is really strong. And I guess one of the key things that I take away is that there are really opportunities to add to the Australian evidence base. And so if you are running studies, if you are running trials, please do reach out to health economists. And if you don't know any, please contact me and I'll be happy to either help myself or to put you in touch with other great health economists across the country. Because while the patchwork quilt has some bits that are covered, there is still a whole lot that isn't and that aren't covered yet. And so making sure that we are continuing to prosecute and add to the evidence base is really important as a sector. In terms of the specific economic evaluations, I thought it's really, I find it really interesting that actually there's really not many at all. So that Matthew et al. Paper found just 5 across the world when looking at it. And I think that's perhaps because of this incorrect assumption that people tend to think that palliative care does not improve outcomes, so they just kind of don't worry about the outcome side of things. And what we showed in one of the first slides, that actually the systematic reviews with high quality evidence show that palliative care is effective at improving outcomes. And so where possible, we should try and capture that. And that overall, of the few palliative care economic evaluations, they have shown that palliative care is cost effective. So really, that's my 45 minutes of walking through the literature. I want to thank you for your time, and very happy to take questions, and I hope that that's been helpful to really set the scene about what we know and what we don't. Thanks very much.
Thanks very much, Chris. On behalf of all of us, that was fantastic, and it was a great overview, succinctly outlined, and I think it gives all our viewers a real insight into the status of where we're at with regard to health economics and palliative care, and a solid appraisal where things are at. So thank you very much indeed. We do have a couple of questions. One, which you may, I think it's probably been answered, but I'll just give your final summation, but I'll ask it anyway, just in case there's anything else you'd like to add. And the participant says, acknowledging the work that you previously undertook, the 2020 Palliative Care Australia and KPMG Palliative Care Economic Report, is there anything else that you think has changed significantly, or anything you or others have learned?
Yeah, great, thank you. I think the evidence base is certainly coming along. So when you look at the dates and the years that the 14 studies that we highlighted through the presentation are published, there's a lot that are 2022, 2023. So there's a whole lot of new evidence coming on board, which is great to see. And in particular, I guess I'd draw a couple of things to the audience's attention. A couple of those systematic reviews around palliative care in community and home-based settings that found really strong results. So I think they're new pieces of evidence that have synthesised the literature really well. And the second one around the use of natural experiments and quasi-experimental methods, which was a 2023 paper that's really trying to extend the methods, improve the methods, and take our clarity around the evidence a step further. So I think those are really the key new learnings. But the overall kind of theme of learnings that palliative care is a cost-effective intervention still remains. It's just that evidence base is building.
Great, thank you very much. And it's a tough question. So see how you go. But I think this is relevant. I think for many of us, one of the participants has asked. It seems that overall, as you've articulated, that there is reasonably strong evidence for the cost benefits of palliative care. How do we get policymakers to invest in palliative care? Have you got any words of wisdom there from your experience or from others?
Yeah, look, and it is tough, and it's really drawing on collective wisdom. I think is critical, but I guess in what I have seen as being influential, it's really kind of putting the pieces together, and those pieces to me are that it's that kind of the right thing to do, and I think palliative care stands really comfortably on that front. B, getting attention, one of the ways to get attention can be to highlight discrepancies, highlight areas where we're perhaps not as good as we'd like to be. Comparisons, we're kind of relative beings, and governments are relative beings as well, and so being able to highlight that perhaps there's inequity in access and outcomes, I think, is always a critical one. And then finally, I do think that the economics helps, particularly just because of that kind of persistent misconception around palliative care that, how could it possibly be adding anything? And in fact, what we know is that it does, and it does so effectively. So those would be, I think, my kind of three key things that I think are important to prosecute to key decision makers.
Terrific. Thanks very much, Chris. And you may not have this information at hand, but a participant has asked, do you recall the health-related quality of life instruments that were used in the forest plot? I think there's a couple of forest plots you presented, but if you don't have that information to hand, don't worry. But so which health-related quality of life instruments were used in the slide you had where you showed the forest plot? But I can't remember the name of that particular study off the top of my head.
Yeah, but it was the Bourgeois study, and apologies, I don't know that off the top of my head, but it does prompt me. But I can obviously, and I will get them for the audience member. But it does prompt me to highlight two people who I know are doing some great work more around palliative care outcomes, and so. Kate Bailey here at the Health Economics Unit is looking at the extension of quality of life instruments to caregivers. And I know that Cara Platts is also doing some work around can we survey and how can we get better information around outcomes for both patients and for families and caregivers. So there is burgeoning research going into to kind of improve that evidence base as well.
Terrific. Chris, I've just, if you don't mind, just a question from me, and I think this is, we'll only have time for this last one. Would you have any advice or suggestions to people who are involved in implementing a new intervention or new healthcare strategy in their setting, but may not necessarily have, a big grant or what have you, if they wanted to do some fundamental kind of costing appraisal? Is that possible, or you really would need to have sort of significant funds and somebody involved with expertise to get some preliminary information that may be useful for subsequent work?
Yeah, look, and I understand the landscape and the funding landscape. It's really difficult to get studies to be funded to the level that we perhaps all want them to be. But I'd absolutely suggest still reaching out to health economists at the start. There is a lot of stuff we can do in the early stages just to kind of back of the envelope it and say, well, does this kind of make sense in the first instance? And if you wanted to prosecute an argument, you might need to, to capture A, B, or C. And that's not a costly or difficult conversation. And so I really would suggest and recommend that. Downstream, the actual finalising and the doing of the economic evaluation certainly does take some time and funding, but at least that initial conversation is something that can be done really simply.
Thanks, Chris. That's really helpful, and I think many of the participants will appreciate that guidance. So thank you very much for the participants in terms of you taking your time to join us here for today's webinar. Thank you very much to the team at the Centre for Palliative Care who were able to choreograph everything so it's run so smoothly. And a particular thank you to Chris for presenting our annual lecture today, which has just been absolutely brilliant. I think his ask was from us was to give us the latest and appraise the evidence as it relates to health economics and palliative care, and you've done that and more. And also, I think I could speak for all. We've learnt a bit along the way above and beyond that, and so we're greatly appreciative, Chris. And for those participants on board, just an FYI, this will be on our Centre for Palliative Care website in due course. Hopefully within the next week or so. So if you want to let other colleagues know who are unable to be here that they can access it, that would be greatly appreciated. But thank you once again, everybody, and thanks for a fantastic Centre for Palliative Care 2023 annual lecture. Enjoy the rest of your day, and thanks again.